I'm going to make an announcement. We're going to be losing quorum around 1:15 today. So we've moved our schedules around so that what we're going to do is hit the action items on the committee reports and then go into closed session for the cases and then come back and pick up the rest of the committee items after that. So welcome to the second day. Before we get started, a few housekeeping items. If you're interested in receiving continuing education credit for your attendance today, please remember to sign in and out on the designated sign sheet. The meeting is being webcast. We respectfully request that when called upon to speak, please come to the speaker's table and speak directly into the microphone. This will ensure those individuals watching the webcast are aware of all discussion and action. As indicated on the agenda, the board has a significant number of items for consideration. Items may be taken out of order. If necessary, public comment on the various agenda items may be limited per individual. We ask that individuals providing public comment be respectful of board members' time and refrain from restating comments previously considered by the members of the board, whether these comments occurred during the committee meeting or during this meeting. Thank you in advance for your consideration and cooperation. Also, as I mentioned, the board will be convening in closed session a little bit later. Upon conclusion of closed session, the board will reconvene in open session and will adjourn the meeting in open session. Board does not intend to webcast the closed session portion. I thank you for all attending. I would now like to take a roll call to establish our quorum. I'm going to start on our right.
Albert Wall, professional member.
Shirley Kim, public member.
Maria Serpa, professional member.
Ricardo Sanchez, public member.
Ryan Brooks, public member.
Debbie Heel, professional member.
Greg Lippy, public member.
Alan Shadd, professional member.
Okay, we've established quorum. The first thing we're going to do is discussion and consideration of board-approved regulations, comments pending review by the board. We have 3 board-approved regulations before us for review and consideration. The first of our for consideration is proposed amendment to Title 16 CCR Section 1707.2 related to mail-order pharmacy consultation. As part of our May 2018 meeting, the board approved text to amend CCR Section 1707.2. The proposal clarifies and makes specific the consultation requirements for all pharmacies, including mail-order pharmacies or pharmacies that deliver medications. I trust that you've all had an opportunity to review the comments as well as staff comments. First of all, are there any questions or comments from members or from public? Okay. I will remind you that page 5 of 5 in agenda item 9 offers possible motions suggested by the staff. Have our members all gone through the possible motions? And if so, do I hear a motion?
Sure, I can make a motion to adopt the staff recommended modified text dated October 25th and notice language for a 15-day comment period. Additionally, should no negative comments be received, delegate to the executive officer the authority to make technical and non-substantive changes as may be required by the control agency to complete the rulemaking file. Should the board determine that all comments be rejected, a possible motion, I did the wrong one. How about adopt the regulated language?
Oh, wait, don't go back. We'll take that one out of order.
Okay.
Tell me which one you did, so.
No,
I think you need to stay with the
Really?
same agenda item.
Just trying to save time.
I appreciate that, but I
Okay.
think we still need to
Go back to
make
the right
sure-
one.
be very clear which item we're
Okay, so
talking.
since we determined that all comments should be rejected, then our motion should have been adopt the regulation language as noticed on August 16th, 2019, and delegate to the executive officer the authority to make technical and non-substantive changes as may be required by a control agency to complete the rulemaking file.
Okay, do we have a second to that? Maria, second. Okay. Comments?
Steve Gray is an individual pharmacist. Forgive me, you, I think, kind of asked for public comment a minute ago, but you were moving so fast and my brain's not
That's
ready.
okay, don't worry.
There was a recommendation or a lack of a recommendation on one item that was in the staff notes.
Just, are you proposing to talk about public comment on items not on the agenda?
No.
Oh, okay, sorry.
No, he's referring to this.
Yeah.
Okay, sorry.
In the staff recommendation, the staff left open and actually said it's up to the board to make the determination. And it was regarding whether, like non-resident mail order pharmacies, are required to have a toll-free phone number for patients to call back, and that toll-free phone number has to be on the label. Where the regulation as proposed doesn't require that for mail order pharmacies that are inside the state. And in fact, there is no requirement under law under 4076 for a phone number to be on the label of a prescription vial. And what's happening is the phone number isn't for the pharmacy, so the patients can't use the phone number that's on the label to call back to the pharmacy to get consultation from a pharmacist, which is the whole point of this regulation.
Right.
So the staff did not make a recommendation on that. What the staff said was basically the board could require a toll-free number for mail order pharmacies inside the state, but it may have fiscal impact, and that's the way they left it in the staff recommendation. So I think that before this regulation is, and this motion is voted on, there should be some discussion about that because I believe that it is a significant issue where a mail order pharmacy in Orange County, Optum Health, for an example, is mailing prescriptions all the way to the Oregon border, and people that want to call back have to use a toll line, where the same person who calls Arizona, doesn't necessarily have to use a toll line because the distance isn't that much. So I think there should be discussion on that, and I think you should consider amending your motion to address that depending on the gist of the discussion.
Thank you.
Hey, Steve, real quick. So is your concern that it's going to cost someone, 15 cents for the phone call?
My concern is that two things. One, yes, the people that need consultation from far away for mail order are more often seniors and others on chronic medications, and the fiscal impact is going to be on them if you don't do something. And the question is the board more concerned about the fiscal impact on the pharmacy or the fiscal impact on the patients? The second thing I am concerned about is that the intent of this regulation and the statute regarding non-resident pharmacy says that the board has to have consistent policies for those pharmacies that are in state and the pharmacies that are out of state. And this is a distinction where the out-of-state pharmacies have to bear the impact of a toll-free number, but the in-state mail-order pharmacies do not. So I think it's actually, and there's law precedent for the state of Georgia where the Interstate Commerce Commission nullified some of their regulations because there was inconsistent requirements in-state and out-of-state. So there's two. Who are you concerned about the fiscal impact? The patient or the pharmacies? And as I mentioned, there is no requirement under law that California pharmacies put the pharmacy's phone number, the actual pharmacy's phone number on the prescription label, but that is a requirement for out-of-state pharmacies.
Yeah.
I'd like to amend my motion.
I think it's the solution.
Okay.
To say that to require all pharmacies to have a toll-free number.
So I'm questioning, and I think I look to council because that seems like a labeling requirement. And I'm feeling like maybe the more appropriate way, if the phone number needs to be included, should be on the label, which I don't think is before the board right now. But I look to council to confirm.
Well,
But
I'm
this
just going
is
by
also
comment.
an 800 number.
I'm
so-
going on the comment number 3, where they said that it sounds like we explicitly say non-resident pharmacies must provide a toll-free number.
So,
So I would, my suggestion is that we have all mail order pharmacies must provide a toll-free number.
Right. And that doesn't necessarily mean it has to be on the label. It has to be provided.
Yeah.
Right, so that takes it away from the labeling issue.
you want to respond or you want me to? So I think what we talked about, and this is, so the pharmacy law right now, probably because it was drafted some time ago before cell phones and the way that current systems work, at least that's my assumption, requires that mail order pharmacies have a toll-free number. There is no, as Mr. Gray said, there is no requirement that pharmacies within California have that.
No, he's talking about a mail order pharmacy located in California.
I agree. I understand that. But I guess my point being that your statutes in the Business and Professions Code has a different requirement. So we can't, I think the perspective was that,
Wait, can I just stop you a sec? Because you said our statutes say a mail order pharmacy has to have a toll-free number.
a non-resident,
Okay.
it's non-resident, not, and I can, actually, can you pull it up while I'm looking? So I think what we had discussed with staff was that having a toll-free requirement has that creates a burden on all all pharmacies that do mail order, even if they do only a few. And I don't know how much toll-free numbers cost, but that maybe that cost could outweigh the current state of how much it costs to make phone calls.
You're saying
To,
that
to
if like
reach
my
them.
pharmacy mailed, because I'm mailing, that would now require me, and I'm in Torrance, California, and I mailed to one of my patients who lives 5 blocks away, but they'd rather have it mailed. Because I'm mailing, what we're suggesting would require that I have a toll-free number, even though I'm not, because we don't have a designation of mail order pharmacy. So by the act of mailing, I have to have a mail order, I have to have a toll-free number.
right.
Okay, I'm not going to make my amendment.
So that was the.
I rescind
Those were
my
the
amendment.
competing requirements. But as Ms. Sodergren mentioned, if you want to have a phone number on the label and require that for everyone, I think that you could very well maybe send that to committee and ask that be discussed on the labeling side. Does that make sense?
Okay, well, why don't we do that?
Okay, so leave the motion as is.
Leave the motion as is and send the number issue to committee for the labeling. Not necessarily an 800 number, but labeling a number if they don't have a number. Okay,
That would be part 2.
right. So your motion stands. Was there a second to your motion?
Yes.
Who did the second? Was it Maria?
Yeah.
Yeah, okay. You did it. Okay. Any more comments? All those in favor of the motion, raise your hand. Looks unanimous. Okay,
We need to make a motion to send it back to committee to consider the phone number issue
yes, we
on
do.
label. So then I'll make that motion.
Okay. Second by Albert. Any comments on this one? Okay,
Which committee would you send that to, Ann?
Probably Committee Fish Public Ed.
right. Okay. All those in favor? Unanimous? Good. We're going to move on. Proposed amendment to Title 16 CCR Section 1706.2 related to abandonment of applications. The board approved the proposed text to amend CCR Section 1706.2 during our February 2018 meeting. The memo we received with our meeting materials included the incorrect summary of the regulation. The proposal updates the application abandonment language to ensure all applicants have appropriate notice about the conditions under which an application is considered abandoned. No comments were received during the 45-day comment period, which was August 30th through October 14th. Are there any comments from members on the regulation? Any comments from the public? Okay. I will entertain a motion to accept staff's recommended motion. Anybody making a motion? Motion
Adopt the regulation language
to adopt the regulation.
Language as noticed on August 30th, 2019, and delegate to the executive officer the authority to make technical or non-substantive changes as may be required by a control agency to complete the rulemaking file. Is that what you wanted to say?
That's exactly what he said.
That's the motion.
Yes.
For a second now.
I'll second.
Okay. Any comments on this? Okay. All those in favor? Unanimous? Moving along. Proposed addition to Title 16 CCR Section 1793.9 related to remote dispensing pharmacy technicians. The third regulation for our consideration is proposed addition to Title 16 CCR Section 1793.9. The proposal would establish the minimum qualifications for a pharmacy technician working in a remote dispensing site pharmacy. As you may recall, during the board's June meeting, the board deferred action on the regulation due to pending legislation also establishing the minimum qualification, AB 690. The governor has since signed the legislation. As such, it appears appropriate for the board to withdraw its rulemaking. Do I hear a motion to withdraw the rulemaking, given that we have the legislation? Okay, Ryan, second by Ricardo.
Okay.
Any comments about withdrawing the regulation? No. All those in favor? Unanimous. Great. Thank you. Now I'm going to turn the meeting over to Alan Shadd to provide a report on the Enforcement Committee activities, and his report will be limited at this time to the action items.
Yeah, thank you, Greg. Okay, proposed amendments to Title 16, CCR 1715.65 relating to inventory reconciliation requirements. As you may recall, in our July 2019 meeting, we discussed CCR 1715.65, which established the board's reconciliation requirements for controlled substances. As discussed in our last meeting, there appears to be some language that needs to be clarified. Both member and public comments identified several areas where this clarification would be appropriate, including the requirements for inventory and reconciliation of ADS devices used in hospitals for unit dose administration, developing a definition of satellite, establishing a minimum frequency for reconciliation activities for Schedule 3 to 5 drugs, and the potential problem to secure initials of all individuals involved in the physical count. Consistent with our action at the last meeting, I've worked with staff and council to draft possible amendments to clarify the language of the requirements consistent with the policy. Attachment 2 includes the draft language for the committee's discussion and consideration. During our meeting yesterday, public comment included concern with the proposed change related to Schedule 3 to 5 and the requirement to perform inventory reconciliation reports versus inventory activities. The committee noted that the proposed change is about consumer safety. The committee contemplated if the reconciliation reports should be provided to the board. We have determined that it may be appropriate as a next step, but should not be pursued as part of this proposal. So the recommendation is for the committee to accept amendment to CCR Section 17.65 as presented in Attachment 2. Also, as part of the motion to authorize the executive officer, council, and the chair to clarify language prior to the initiation of the rulemaking, consistent with the board's policy.
Okay, so that's a committee motion. We don't need a second. Is there any, are there any member comments to this? Any public comments? Okay. Mark?
Good to see you again, Mark.
Thank you. Mark Johnston, representing CVS Health. Just a little reminder of my background. I was president of the state association in Idaho. I worked with NABP extensively, so I feel like I have more of a comprehensive view of pharmacy. And I believe that one of the board's roles in public safety is to increase or maintain access to care, as well as all of the benefits that come from expanded pharmacist practice, such as all the great furnishing laws that were passed in California. Unfortunately, in a report that came out about 2 weeks ago, it identified that 12% of the pharmacies have closed in the last couple of years in America, and that's left a gap in access in inner cities and in rural areas. I can speak from CVS's perspective. It seems as though we're opening more pharmacies, but we're actually closing a significant amount of pharmacies. Reducing hours, especially on the weekends. There's hardly any 24-hour stores left, and that's not just CVS. If you look at all the other major chains too, there is a trend as a decrease in access to care, not an increase in access to care. To address this, at the NABP district meeting, 6, 7, and 8, where nearly half the country was there, California is part of that district and unfortunately wasn't able to attend the meeting. The whole theme of the meeting was for boards to act under this new concept of permissionless innovation, where they review their laws, reduce administrative burden, and the resultant effect of that is that smart people create inventive solutions to crises, and I think we're pretty much in a healthcare crisis in this country. So several states like Washington have reviewed, and they're about ready to half their rules or whatnot in the name of public safety, to better public safety. The inventory reconciliation rules that went into effect a couple of years ago came at great cost. The cost that CVS is investing in an IT solution. The IT solution is up around $1 million now, and that's a good investment because that's going to save money in the long run, because the cost of labor was going to be more than that just to implement the C2s. As you increase the cost and the administrative burden, it's one of the things that equals decreased hours, decreased overlap in pharmacist coverage. We're trying to expand pharmacist care through all the great furnishings, and there's a direct correlation between not being able to do the expanded pharmacist care because we're doing things like inventory reconciliations. CVS has announced and has opened in 5 states now a great new concept called their hub pharmacies. It's really pretty amazing. We bought Aetna, and when you don't have to worry about payment to the insurance company because it's all one company, it's amazing the information that can come down from Aetna that helps pharmacists make people more healthy. The information that comes down, such as you haven't had your A1C for diabetes, you haven't had a blood pressure test, and how the pharmacist can integrate and help make people healthy. It's really an amazing program. Because of that, CVS announced they were going to advance into 1,500 stores in the next couple of years. I can tell you I've seen the list of expansion. There's a handful of California stores, and that's a proposed list because of the administrative burden in California and the regulatory environment. It's heavy in the states that don't have as much administrative burden in a different regulatory environment.
Mark, because of time here, can you kind of sum it up?
Yep. Getting to my asks, I have 3 asks. One is to make an evidence-based decision. Has inventory reconciliation reports of C2s made a difference on the opioid crisis? Can you prove a correlation that would equate to expanding it to C3 through 5s? Is there evidence, or is this a different decision that's not evidence-based? The second would be to perform a financial impact study. The law requires that for small businesses, so, I mean, you have to do it anyhow for small businesses. I would ask that it's expanded to larger businesses so you can fully understand the administrative cost that will be. What are there, I don't know, 10 times the amount of C3 through 5s as there are C2s. I mean, it's going to be hugely impactful. And the last, I asked to send it back to committee to consider just targeting certain drugs. Yesterday, we heard Phenergan with codeine is a big problem. Why all C5s? Why Lamodal for diarrhea that I don't think is abusable? Why would we have to do inventory reconciliation on all those drugs when Phenergan with codeine is the one C5 that's targeted?
What about tramadol, that's a 4 or a 5, right?
Yeah, I mean, maybe
that's
maybe it's
pretty-
all opioids. Maybe, but maybe all the non-opioids aren't the problem we're trying to address. It's an immense amount of drugs. All C through 5s is an immense amount of drugs with an immense burden. Perhaps it could be targeted instead of throwing the baby out with the bathwater, if you will.
Thank you.
Thank you.
Well articulated.
Really quick, thank you for those comments. Would it be useful, I think, for this board and maybe a committee that will hear this, if you have a list of those regulations that are burdensome, provided to the board, and we'll take a look at it. I mean, if it's not useful, why are we doing it? So I'm in agreement with that, but if you provide us with a list, I think it'd be helpful for the board to tackle that list.
Absolutely.
Yeah, thank you.
Thank you.
I'd like to comment on
Maria.
maybe we should look at this instead of taking everything all at once, but incorporate the suggestions and maybe look at maybe the 4s and 5s for individual items, but maybe to include 3 as a group, but maybe not all 3, 4s, and 5s, because I do see that his comments are valid in that it could be a very onerous process for a large number of medications that are not high in abuse potential, and maybe taking a stepwise approach.
So it should go back to enforcement committee, you're suggesting?
I think that'd be fine.
Is that fine?
Yeah,
I think we should.
Okay.
I
you have a
actually
board
have a
member
question about the reporting. It keeps talking about someone signing off on a report. Is there a way, because I think in some cases the reports are electronic, so is there a way to,
Electronic signature?
yeah, to acknowledge it? I mean, I don't see in the language where it really seems like we could do it that there's an electronic trail, as opposed to having to print something, have someone sign it, and then file it. Has that been looked at?
Well, not specifically. Not specifically. And so maybe that's another consideration, but we don't want to get too detailed.
Yeah.
No, I agree, but we are detailed because we say something about, let me look at the language. It keeps talking about, shall count.
Initials
and
of everyone.
And they shall sign and date the document of the count or the reconciliation report. So I guess, I'm just thinking, this report, it keeps talking like it's a piece of paper. But I think in some cases it probably is a piece of paper. But I think in a lot of cases it's no longer a piece of paper. It's an electronic document. So there's not anything for them to print and sign. So I guess as we send this back, I would like to.
There's a lot of talking here.
Ann and I are doing nonverbal communication about who's going to answer, and hopefully we're going to go the same place. I think when the board initially adopted the regulation, the analysis there was that the physical signature makes it so that you can better track from a regulatory perspective who did the counting. That doesn't mean you can't change, but there's a difference between, I mean, much like a pharmacist's signature on a label, you can verify that, whereas in an electronic system, it's much harder to say, oh, I was logged in, I didn't walk away, and so-and-so used my number.
And I think you have the right things in place, because a lot of them, there's like biometric or scanning document. That would work too, but the way this is worded, it sounds like it's a piece of paper. And I remember when we were going through this originally, that we were trying to be flexible with people who had electronic systems and not make them go back to paper signing and like on a certain day everything has to be counted, because there's a lot of them that I know in my work that,
Yeah, well, something like a DocuSign.
or some, whether it's an e-signature.
Well, I think it's a
or-
little difficult because it's similar to the biennial DEA requirement, and so that's a printed out document. So I think that's probably why the report is signed, but the inventory themselves do not need to be printed and signed because they're electronic.
But you can still have it signed by the e-signature. You don't need to.
Or some sort of bio, it could be a biomarker. I mean, because in some places, and so I know the CVS system, we do credentials.
Microphone.
My microphone's on. Am I not talking loud
You're
enough?
not-
So I know that in some places you actually
Ryan?
have
Ryan,
credentials.
microphone.
And so the
I think-
credentials would take care of that. Like,
Okay.
in the system, you have credentials, so it's not like I can do something and Ryan can come, the old way, where I do something and Ryan comes along, looks like he's using my credentials, can't happen.
So one of my concerns about sending this back to committee is that there are a couple of things that are urgent that need some clarification, and that is the definition of pharmacy satellite and the automated dispensing machines. And so I'm concerned that if we send the entire thing back to committee, that confusion will continue for many, many more months. I'm just wondering, in our previous discussion about taking back the discussion about 3, 4s, and 5s, if that could be removed from the proposal for discussion later, and is it possible or is it prudent to move ahead with the other parts, which are to clarify some of the confusion in the community?
I think that's an excellent idea.
Can we
Excellent.
do that?
So would it be helpful to sort of give you a perspective about where you are in the process? And this is sort of,
Yes.
if you think about in rulemaking world. So the first thing that happens is the board authorizes the beginning of a rulemaking, and then you publish the text. As you know, that takes some time. You notice it,
period.
you receive comments about whatever it is. Then if you decide to amend the text, then you can amend it, but you notice that as well. Usually that process takes up to a year. So if the board did choose to authorize language, whether it be what the committee reviewed or a modified version of that, you're probably looking at about, I would say, a minimum of a year,
Regardless.
regardless.
Well, I guess my thought is it's going to take a year. So I think I understand the urgency, but understanding that it's going to be a year before.
Yeah, we might as well fix it.
Yeah, let's fix it. Let's just push it back. We're back together in July, so we're talking about 2 or 3 months.
When's the
let's
next
make it right.
enforcement meeting, though? I'm not sure we
Crap in,
have,
crap out.
we don't have an enforcement meeting calendar, do we?
Yes.
Yeah. When's next enforcement meeting?
What is it, Steve?
29th of January.
Yeah.
Oh,
It's only a couple months out. Okay, so,
So can I suggest something, and I might be going out on a limb, so I'm apologizing in advance. I think that there might be a way to communicate that portions of the regulation reflect where the board's going from the policy perspective with respect to perhaps the ads physical counting or something like that. So although it's not fully implemented in the regulation, this is where the board is going from a policy perspective. I don't know if council's looking at me going, what the heck are you saying?
and I think the regulated public, that would be helpful just to have some idea on those 2 high-profile issues, because right now I understand it is an enforcement challenge that they're having at the sites regarding the definition of satellite pharmacy and the use of automated dispensing units.
so how would we accomplish that?
We accomplished it through our guidance to our site enforcers.
Okay.
That's probably the easiest way.
But in terms of communicating to the public,
How do we communicate the policy?
is it through our
don't know.
normal, through a website or through
Or do we make a
newsletter,
motion
or how are we going to do it?
Well, I think that's an administrative issue on
Right.
whether we enforce or not. I mean, that's
Right.
an administrative.
So if, I
But we
guess
need to let the public know what we're
maybe what
doing.
would be clear is if the board does take an action to send it back to committee to specify that the board is comfortable with those 2 aspects of it. Did I hear the ads and the satellite? But that the board is interested in more feedback about the others, you know, the other 3 schedules, 3, 4, and 5, and the signature.
Okay, so that's your
So-
motion?
Well, so I'm wondering, Maria, when I look at this, is it subsection G and H where G addresses pharmacy satellite and H addresses ADDS? Are those the 2 clarifications that you're referring to?
I think that's what I'm looking at, and if staff see that they've included it someplace else, I'm not quite sure if it's elsewhere. Those are the 2, I think, clarifying areas.
So you can make the motion to send back and to also designate that we're accepting our policy is to go along with those 2 items.
I mean, I'm happy to make that motion. Do you want me to make that? That we're going to send this back?
Yeah.
But as a policy, in the meantime, the board accepts as part of our policy what is outlined in sections G and H?
I agree to that, but I defer to Mr. Shad
Yeah, no,
as
I
the
think
chair.
Okay,
we've got forward progress that way. We've got the details we're going to discuss, and we'll have a proposal by, in January.
And again, and maybe part of my motion, and maybe this is 2 motions, but we're sending it back to committee to discuss which schedules should be part of the reconciliation and possibly also look at the
report signing.
how the report is handled.
Right.
If there can be an electronic option or something.
Okay,
Right, and there'll be further discussion on that. That's-
okay, so that's the motion. Do we have a second?
Second.
Second by Maria. Comments?
Yes, Steve Ray, hopefully some helpful comments. I support the motion for it to go back to the Enforcement Committee meeting. They do have a meeting coming up. I would suggest that the committee wants to be very careful about some blanket language that said, well, we'll just say all opioids. And the reason for that, I think you'd be better off to pick the particular drugs that you're having a problem with. And the example I want to give is you're having a problem, we all know, with promethazine with codeine, and it is an opioid-containing product. But so is Lomotil. And Lomotil, you probably don't know, is an
Not having a
opioid
problem.
product, but it's also in the top 200 drugs that are dispensed across the United States. And so the reconciliation burden on that drug alone is disproportionate to what you would be preventing as probably a problem. So I would say, you know, the committee really needs to take a look at which drugs inside of Schedule 5 are problematic rather than just saying blanketly all opioids. That's my point. The second
Understood.
comment is related to the signatures. You know, there is a federal law called e-sign, which basically establishes the legal presumption that all electronic signatures are valid unless specifically called out by a regulatory. And they wouldn't have done that if they weren't confident in the current technology or the possible technology used for electronic signatures, which is why they're so prevalent. And even the DEA prefers electronic signatures, electronic prescribing of Schedule II items over, you know, the handwritten from an evidence point of view. And as to the comment as to the initials on the label by the pharmacist, if you actually walk into a pharmacy and hold up a bottle and challenge the PIC as to whose initials those are, you know, there's usually not a clue. And so the hand signatures are actually very hard to validate legally in evidence. And I would encourage you to take a look at electronic signatures as much as possible.
Thank you. Any more comments?
Yes.
Albert.
Oh,
Yeah. I want to comment on the overregulation. Like I said at a lot of meeting, I say don't fix anything that's not broken because every time you have a new regulation, a new law, it costs a lot of money to implement them. And I don't find the inventory of the opioid is that much a burdensome. I see my staff doing it. It didn't take them that long to do the reconciliation. So I don't think we should remove any thing from the list. And also, the previous speakers speak about a lot of pharmacy closing. I think he forgot to mention one more thing. is a lot of pharmacy closing, especially community pharmacy closing, is the PPM reimbursement. That's the killer, because it's, like I said before many times, that's many times we fill prescription, we lose money. Sometimes not very big. It's not simple few cents. It's we lose big time. So it's the PPM is causing all this community pharmacy closing.
Okay. Thank you, Albert.
So apologize, I wasn't able to be at committee yesterday, so if this was already discussed, just stop me.
Well, it wasn't discussed by you, so it's okay.
Okay, thank you. John Gray, I'm a registered pharmacist with Kaiser Permanente. Just a couple quick questions or kind of flags since this is going back to committee. As I read this, it wasn't entirely clear to me for subpart G whether an ads is a pharmacy satellite location, but then subpart H further modifies the requirement on an ads. I just wonder if it would be reasonable to specifically call out that an ads is not a pharmacy satellite location, and then continue with the requirement as it's proposed under subpart H. It still seemed unclear to me whether it was or wasn't.
And what would you do on that?
So I think I would probably defer to council, because I think I think it's how it's constructed that they stand on their own, because I think that there may be hospitals that have, in fact, do use ads in their satellite locations. So I think that they are intended to stand on their own, but
So I don't think I want to give an answer right now, because I think what the board is focusing on is sending this back to committee. But to the extent that there's a clarity issue, we can certainly see if there's something to clarify that piece.
Okay,
Thank you.
thank you.
So where does this stand?
We have to vote.
I know, but with John's comment, does that change anything?
No.
Okay.
Okay, we have a motion, we have a second. All those in favor of the motion? Yep, unanimous. Sure.
when we release our action items from our meetings, we both send them out via subscriber alert and then we post them. And it feels like that might be a good place to convey that the regulation is going back. However, the board's current policy with respect to ads and satellites is reflected. Do you feel comfortable with us disseminating that?
Yeah.
Yes.
Right.
That was my point before, how we get it out to the public.
So hopefully that takes care of it.
Right, thank you.
All right, the next action item was AB 690, but you've already done that?
Yeah.
Okay.
So there is the one piece on 690 regarding the affidavit.
So how the application is, that experience, right?
Yes.
Is verified on the application.
Where is that?
So the committee took a position that in applications on.
Oh,
the
requirement for the
USB
remote,
to
Oh, they be signed affidavits from the pharmacy technicians confirming the compliance with the statutory. Yes, yes. So that part was not included in yours. So we have a committee recommendation to include as part of the application requirements for the remote dispensing pharmacy application, signed affidavits from the pharmacy techs confirming compliance with the statutory requirements. So now that's the committee motion. So do we need a?
No, we don't need a second,
Okay, great.
but we need comment, so if there is any.
What agenda item is?
So, may I?
Yes, please. That's under
So it's
690.
it's Roman 10, Roman numeral 10 on the board's agenda, item
it's D2.
D2, AB 690. So that's the bill that,
She's got it.
okay, that's the bill that would sort of took over the board's regulation.
I'm sorry, can you say again what the committee recommendation is?
Okay, so, okay, the motion was to make it as simple and streamlined as possible for the requirements of the text that we already signed. Rather they have to prove it, or rather they can just say that they've done it and we can check on that, spot check on that later.
So-
And so,
Attestation kind of.
yeah, Right.
Right, so on their applications, in lieu of proving that they've gained the, I think it's 2,000 hours of experience, instead of submitting employer affidavits or W-2s or something like that, the technician or the applicant can simply sign under penalty of perjury.
So the motion is to accept the signature, the signed
Is to,
affidavit.
yes.
Okay. Any comments? No. Okay. All those in favor of the motion, raise your hand. Unanimous. Go ahead, Alan.
All right, on to 159. This measure establishes the authority for pharmacists to provide HIV pre-exposure prophylaxis and HIV, post-exposure prophylaxis under specified conditions. The chair report details out the specific conditions for both in PEP and PrEP. Specific to the provisions of the bill, we'll need to have emergency regulations in place by July 1, 2020. Areas for regulation will cover training program requirements, and if new drugs come to market, regulations that identify these additional products. And that the pharmacist has the ability and authority to furnish. The language is included in Attachment 9. During the meeting, we received significant public comment on the importance of the measure and include a written statement for Senator Weiner, the author of the measure, which was read into the record. A copy of the statement was made available and provided to the members. Dr. Gaspar, who has assisted the board in the past with development of training programs, has offered his assistance with implementation as well as several other members of the public. During our meeting yesterday, the committee noted the significance of this legislation. It appears appropriate from the Communications and Education Committee to consider an education campaign for both consumers as well as pharmacists. Our committee discussed the need to develop regulations quickly and noted that the regulations must be developed with the medical board, and staff will need to coordinate efforts with both the Office of AIDS, medical board, and other stakeholders. So the committee recommendation is, as a committee, we determined that such development could be referred either to the Legislation or Regulation Committee or to the Licensing Committee, as decided by the full board. And what's the pleasure? What do you think, Ledge?
Okay. I think at this point I've rethought it, and I think licensing is the place for it to go.
Yeah, if he's licensing someone who's.
Sure.
done some of the-
Sure.
The other protocols.
That's what I thought, but I didn't want to go against the new president, so.
Thank you. So the motion is to send it to licensing.
Right.
Okay. Any comments from the public? Okay.
Great.
All those in favor of sending it to licensing? Unanimous.
Okay, is that all the action items for my committee?
Let's see, you've got
Was there also a motion to
569.
send the public campaign to the, oh, they didn't? Okay.
So what's the answer?
There might be one on,
Yeah, that's what it shows here. You have one on AB 5 or SB 569.
One more? Hang on. Oh, 569, the one that's highlighted. Okay. Okay, 569. Controlled substances, prescriptions declared local or state or federal emergency. As included in the chair report, pharmacists will have the authority to fill a prescription for a controlled substance that does not conform to the Controlled Substance Security Form requirements under the following conditions. Number one, that the prescription form indicates that the patient is affected by a declared emergency. 2, the prescription is written and dispensed within the first 2 weeks of a notice issued by the board. 3, the pharmacist exercised appropriate professional judgment, including reviewing the cures system prior to dispensing. 4, it limits the dispensing of a Schedule II to no greater than a 7-day supply. 5, requires confirmation that the patient is otherwise unable to access medications. Verification of residency within the evacuation area is one of the acceptable forms of confirmation. 6, prohibits the refill of a prescription dispensed under these provisions. The committee noted that the board routinely issues a subscriber alert when declared a disaster is made. This alert can serve as a notice required to be issued by the board. Further, it appears that appropriate to detail out the provisions of this measure in the alert. During this current declared statewide disaster, our website was updated to include a list of resources for consumers and pharmacists. Incorporating this information is appropriate as well. Our committee also discussed that it would be helpful to provide pharmacies with guidance on possible implementation strategies. So the recommendation was to authorize board staff to work with the chair to develop guidance strategies to disseminate.
I have one question. Number 2, within the first 2 weeks of a notice issued by the board, it seems like the other emergency things are based on an emergency issued by the governor. So why did we do this one by the board?
It's how the legislation was enacted.
Okay.
Yeah.
Any member comments? Any public comments? Okay, all those in favor of the motion, raise your hand. Unanimous. Thank you, Ellen. Now, the next item is related to legislation regulation. I will turn the floor over to myself, being chair of legislation regulation, and I will tell you there are no action items. So I will now turn the floor over to licensing committee chair Debbie Veal.
Okay, we have quite a few motions and action items, so I'm going to try to go through this as quick as possible. I'm going to assume that everyone has read the background information, so I'm going to just try to, for the most part, to cut to the chase. So the first item is the discussion and consideration of advanced practice pharmacist license requirements to qualify in Business and Profession Code 4210. What the committee is recommending is that the staff work with council to draft a statutory proposal that would define if completion of one requirement as identified in BPC 4210A2 is assumed to be completion of another requirement specified in the 4210. Further, to accept if certification is earned as part of the requirement for completion of a residency or completion of 1,500 hours of collaborative practice experience, or residency is completed that includes the 1,500 hours. So that's the motion by the committee that we would like the board to accept. And then once it's accepted, we actually have, if that's approved, then we actually have some statutory language to present. Does that make sense? We have a couple of these where we went through it, we asked staff to move forward with language, and if you're okay with our decision that we should move forward and our premise, then I need you to approve that, and then I can, as a second step, present the language that we're proposing. So a lot of these are kind of 2 steps.
Okay, so are there any member comments? Public comments? Okay, all those in favor of the motion? Unanimous.
Okay, so there was at the back of the room, let me just find the right one. Back of the room, there's 4 different items that we are proposing today and that we worked on. And this is proposed statutory language, advanced practice pharmacists, and you'll see that the 4210, there's one change made, and that is in 2 subsection B. We added, for the purpose of this subsection, if a condition of completion of one of the required criteria fulfillment of a second criteria is also required, such completion shall be deemed to satisfy the requirement for this section. So in other words, we're saying that if in doing one of the, you get 2 or 3, and if in doing one part of it, let's say you're doing a postgraduate residency, and in order to complete your postgraduate residency, you have to complete BPS accreditation. Then, in fact, you're completing 2 of the items. In the past, we've called that double dipping, and we haven't allowed it. But so what we're trying to say is that's probably not fair because there's a lot of effort going in, and the individuals are in fact completing, checking 2 of the 3 boxes, which is what the requirement was. So we are hoping that B kind of clarifies this and in certain specific situations allow 2 of the items to be completed as part of your process. Does that make sense? I mean,
Yes.
Yes, absolutely. I think it's fair.
Okay.
okay, so the committee has also, the motion, because the committee hasn't had a chance to really look at this, I'm going to need a second. So if one of the committee members would like to second this, I would like that. But our motion is approve the statutory language to amend BPC 4210 as drafted and to direct staff to secure an author to sponsor the statutory change.
Okay.
You want to second that motion?
I'd second that.
Thank you, Ellen.
Okay. Okay. Any comments by members? Any comments from the public? Danny?
Been awful quiet. I was wondering what was going on.
Wasn't paying attention. Danny Martinez with the California Pharmacists Association. I just want to clarify. So I know at the committee level we discussed that there was that one issue where you couldn't really complete the residency and provide the clinical services. Does this language fix that issue?
We believe so.
Okay, great. Thank you.
Good, yeah. Okay. Seeing no other comments.
Hoping that it was so clear that you wouldn't have to ask that question, but it's okay.
Thank you. Okay. All those in favor of the motion, raise your hand. Unanimous. Go ahead.
Okay, the next one is using ADD. So
ADDS.
ADDS, yes, sorry, thank you.
We don't want to confuse it with ADD.
So there's a lot of relevant law that's referenced in the materials, and what we're trying to clear up here is, I think it actually went into effect like a year ago, wasn't it? Or July of 2019. And so in living through the implementation of the ADDS, the staff has, identified that there are some, maybe some gaps specifically in locations where we could use the ADDS machines that we'd like to modify. And so, first we thought, oh, easy, we'll just add in HCS 1250, which identifies quite a few different types of facilities. But then our esteemed executive officer said, gosh, that probably really doesn't cover everything. One of the stakeholders suggested that we use language that has the authority, any place that has the authority to administer drugs and would require an ADDS to be licensed by the board. So this is kind of the long story at saying we wanted to come up with some statutory language to better address all the ADDS locations that can handle medications today, but also make it flexible enough that some of those locations that maybe we can't think about today and maybe in the future would also be covered. So the committee motion, so once again, this is a 2-step motion. The first motion is to agree that we should establish some new language, and then if we agree to that, I will present the new language that we've put together since our meeting. So the committee motion is direct the staff to work with council and the chair to develop statutory proposal to expand the locations in which ADDS can be licensed to include all facilities listed in HCS 1250, as well as other locations licensed by the state that, as a function of their underlying license, are authorized to offer medication services. That is the motion by the committee.
Okay. Any member comments? Public comments? All those in favor of the motion?
We have a public comment.
Sorry, Mark, didn't see you.
Mark Johnston, CVS Health, and in the family of pharmacies is Omnicare, so this directly relates to our business. I wanted to thank the board for these proposed changes. I haven't had a chance to read through the 3 pages that I just picked up in the back of the room, but you know, the simplistic approach that you've developed instead of listing out you know, dozens, if not hundreds of different facilities is a great approach. I wanted to give one example. PACE facilities are, my understanding, a facility where, you know, folks can live on their own, but they need some help with certain services such as medication. So they go to a facility to get their medication for the day and some other services. They're licensed as adult day health care facilities. Certain ones are registered as primary care clinics. Oddly enough, in order to get your ADHC license, you have to at least qualify for a primary care clinic license. And I say qualify because a nonprofit entity can indeed obtain the PCC license. A for-profit PACE facility cannot, by law, obtain the PCC license. So the Department of Health has developed a system where they go in and they certify that you meet all the requirements of PCC, but we can't actually give you the license, and that's good enough to at least get the license as the adult day health care center. So if you're following me, the reason it's important is because the ADDS language says that if you have a PCC license, you can get an ADDS. So the nonprofit PACE can get an ADDS. The for-profit PACE cannot. Now this law will change that, but you know, it takes a long time to promulgate a change or to go to the legislature. I guess this would be a bill to enact a change. Seems kind of an unfair situation. I was, you know, maybe hoping that there
Looking
can
for
be
a policy.
a policy, an FAQ, enforcement discretion, because it seems like a real imbalance based on something that doesn't affect public safety.
Thank you.
Thank you.
So if the board
ahead.
would like me to address that issue, the challenge with that is that the legislation currently requires that an ads license be issued, so the board can't use enforcement discretion to do something that's not authorized by law.
Darn. Okay, I guess we're stuck. Okay, we have a motion. Do we have any more comments? No. All those in favor of the motion? Unanimous.
Okay,
Continue on.
so we just so happen to have proposed language here that was handed out this morning. ADDS statutory language that we worked with council, the executive officer, and myself to make the changes. And if you read through it, you'll see there's quite a bit underlined. I'm not going to read through all of the changes, but once again, please know that the purpose of this is to make sure that we are allowing ADDS or AUDS machines to be locations to be added.
Say one thing really fast, and that is that a lot of the language in here is actually just restating existing law that's found in the Health and Safety Code to make it apply. So while it looks like there's significant change, the majority of it is just restating what is in 1261.6 to ensure that people know that they need to comply with those requirements.
Okay.
So it looks significant, but it's really not as.
Okay.
So the motion that I will need a second for is approve the proposed statutory language to amend BPC 4427.3 as drafted and to direct staff to secure an author to sponsor this statutory change.
Okay. Any? We have a second. Okay.
May I just clarify that that amendment includes also adding the new sections as well? It's the totality, not just the amendment.
Okay.
Yes.
Yes, thank you.
Accepted. Okay. Any member comments? Public comments? All those in favor of the motion? Unanimous. Continue.
Okay, the next item, we were a very busy committee at our last meeting. Our next item is to align the self-assessment requirements that to be consistent with the law. And this, once again, has to do with ADDS machines. The 4427.7 and 411911 requires ADDS licensure to complete an annual audit. However, Section 1750 of CCR specifies it shall be performed before July 1st of every odd number year. So what we wanted to do is try to amend the language to align the requirements. Now, this one, actually, the statutory change is in your meeting material as attachment 2, and it contains the changes to both BPC 4427.7 and 4119.11. So the motion from the committee is approve the proposed statutory language to amend BPC 4427.7 and 4119.11 to align the ADDS self-assessment requirement with the pharmacy self-assessment requirement and CCR 1715 as drafted, and to direct the staff to secure an author to sponsor this statutory change. No second is needed, although I'm sure Alan was ready to provide it.
I was poised and hoping.
Okay, any member comments? Public comments? All those in favor of the motion that requires no second? Thank you, unanimous.
Next is discussion and consideration of legislation to amend BPC Code 4312 to expand the provisions to apply to all facility licenses. So currently 43, did I say 4212? I meant to say 4312.
You said 4312.
Okay, good. Currently, 4312 authorizes the board to cancel licenses for wholesalers, third-party logistics, pharmacy, veterinary, food, drug retailers, and outsourcing facilities if the premises remains closed. But it does not, the statute, because it names all those different organizations, doesn't include everybody. And so what we want to do is we want the law to be amended so that that if a establishment remains closed, that it too will be, its license too would be considered invalid. So this is also in your packet in attachment 3. And so what we're trying to do is a law that is, allows new and existing license types to be included in the statute. So once again, trying to be more flexible and looking forward to the future as far as not only the items that are, the organizations, licensees that are listed, but also possibly things in the future. So the committee motion is to approve the proposed statutory language to amend BPC 4312 as drafted, and to direct staff to secure an author to sponsor the statutory change.
Okay. Any member comments? Public comments? All those in favor of the motion, raise your hand. Unanimous. Continue.
Let's see. Now this is, next one needs this too, okay. So the next one is discussion and consideration of amendments to Title 16 CCR 1709 to specify required reporting requirements for individuals vested in management and control. So this goes back to like about 2016, and then there was also a subsequent passage of Senate Bill 1193. But so, and we hadn't ever really been able to secure the changes that we wanted in 1709, so we're kind of trying to clean this all up and bring everything together. And so we thought that we needed to have some kind of fine tune the changes to 1709. So the committee wanted to talk about reporting, how to best put out reporting changes to individuals exercising management and control, changes to individuals who are exercising management and control over a licensed facility. So we wanted to incorporate our changes these changes into 1709. Once again, this is going to be a two-step process. First part is a committee motion that was to direct the staff to work with council and the chair to incorporate changes into the regulation to require reporting of any person with management or control into Title 16 CCR Section 1709, and to incorporate this change into the current regulatory package. So that's
Okay.
the motion by the committee.
Okay. Any member comments? Public comments? All those in favor of the committee motion, raise your hand. Unanimous? Continue.
All right, so this is one of the documents that was in the back of the room, and it is the amendment of 1709. The probably, I don't know, I think the key changes are B1 and 2, don't you? So the main changes are in B1 and 2. B1 says any transfer in a single transaction or in a series of transactions of 10% or more of the beneficial interest in a business entity licensed by the board to a person or an entity who did not hold a beneficial interest at the time of the original license was issued. Or 2, any transfer of the management or control over a business entity licensed by the board to a person or entity who did not have management or control over the license at the time the original license was issued.
And these are, these require written notification to the board within 30 days.
Right.
Okay. Okay.
So those are the main changes. There are others, some I think.
Yeah, actually, B1 is actually just restructured. That's existing law. We're just to format and, I don't know, make it legally appropriate. It's broken down differently. So that's an existing requirement, but we have to show it as new. It's 2 is the new.
Okay.
Okay.
And the language that you see there in underline is previously approved by the board, but still in draft.
Okay. Any member
Right, single
comments?
underline.
Public comments? Okay.
Comment.
So, this is something that we've been trying to comment on for almost 2 years now, a little over 2 years now. We sent a letter back to the board on July 25th of 2017 on this issue. Since this is now agendized before the board, I'd like to mention some of these concerns that we have. Specifically 1709 D1, which I understand has already been approved by the board, but I like the reconsideration of the board of this text. This talks about, as part of its application and during its annual renewal, the entity shall also report the name of any other person in any position with management or control of the pharmacy. We believe that not only is this not unclear, but it's hugely problematic because there are staffing services, billing services, and legitimate management companies that provide numerous pharmacy operation and financial services that aren't relevant in the licensing of pharmacies. And so, as we're considering this again, I'd ask that the board revisit this because we do believe that there is a need for this, but the focus needs to stay on ownership matters. And this particular regulation D1 should be stricken from the regulations for consideration, given the reasons I just stated. Additionally, we have.
Can I ask you a question?
Yeah.
Before you go on? So management or control, I don't feel like the entities that you just listed would be management or control, a relief pharmacist, a billing person. I mean, that's not management or control people.
Or staffing.
Yeah, staffing, wouldn't it be a management or control, staffing service?
I mean, so, and again, admittedly, this is a 2-year-old document, so this is actually something that when I first started at CPH, I started to learn about, but given the delay that this regulation has had, my understanding is that there are pharmacies that use these services, particularly for staffing and billing. We're concerned that the board or any sort of enforcement matters may interpret this as such down the line. And so,
I mean, I
This
don't,
is transfer of beneficial interest.
So one,
Which one's
so
it?
one option that
Oh, okay.
the board has is this language has not yet been noticed. And so you're going to have additional public comment. And if the board or the committee, the board and the committee previously heard the comments that Mr. Martinez is referring to, it doesn't stop CPHA or any other person from making those comments again during the rulemaking process, and then the board will have the opportunity to amend the language at that time.
I guess I see the management and control being the
Yeah.
people who hire those staffing services and billing services.
right,
not-
but
not
if the
company.
pharmacy's report is required to report this, I guess my question at that point, why is that relevant for the board?
I don't think we're asking for you to report the staffing services and the billing services.
Well, it says any person in any position with management or control. So management, I would say, if you're managing staffing, so if you're contracting the staffing, of your pharmacy to a separate entity, would that not be considered management?
No, they're talking about in the management of the company.
Yeah, so you're the owner of the company and you're contracting with Danny's
Okay.
staffing services.
Well,
So
and-
I would have to be listed, but Danny wouldn't have to be.
Okay. Well, I guess some of our folks had disagreed on that interpretation, and yes, we will be submitting comments during.
Yeah, and
the only thing
maybe,
I'm
and
gonna.
if- and we're open if you think we need to somehow clarify exactly what
Yeah.
management and control means.
The only thing I will say, and about the notice of, the public comment period, the 45-day comment, is that I hope that this board takes that comment period seriously. I've seen in the past where, some comments are made based on something that we might consider controversial, and it just kind of goes, well, we just reject it, and, kind of give like a, secondary basis as to why. This is something that, as I've mentioned, this is particularly concerning anytime there's sort of information that's being reported to the board that we don't understand why the board would necessarily need that information. I just hope that this board really takes that into consideration.
Agreed.
Thank you.
Thank you.
And we anticipate you holding our feet to the fire to make sure that we don't just let it blow by.
Hi, Steve Gray, as an individual pharmacist, but also there was some comment that was put forward through me through CSHP about looking at this whole thing from the aspect of hospitals and the way they are under management and control, and particularly not only hospitals, but entities such as pharmacies that are where no individual has a beneficial interest. And the problem I see is more with B2, where you don't have the qualifier in B1 of someone who has beneficial interest. Because in a not-for-profit organization, no person has beneficial interest. In a government licensed facility, correctional facility or otherwise, no person has beneficial interest. And yet, those entities do have people that are in management and control. And the issue is, where do you draw the line? So would the state of California that has licensed facilities that are licensed by the Board of Pharmacy have to report to the board that there was a change in the governor, ultimate administrative authority over those licenses facilities? And I'm not trying to be flip. I mean, where do you draw the line on not-for-profit organizations in terms of the defining of who you want to know has management and control? So I think it does need to have what Board Member Veal just mentioned is some more clarification on what you mean by who has management and control. Literally, some of these corporations have hundreds and hundreds of officers that have some aspect, as the previous person said, of management and control. And they may or may not have beneficial interest depending on the way the organization is organized. And what do you really want? Now, in the past, there have been what I call sub-regulatory processes to handle this, which is the board would say, okay, for your corporation, I only need 5 people that we can hold responsible, even though in the line of authority for any individual pharmacy, there may have been 24 people in the chain of command that have control over that pharmacy. But I think there needs to be some clarification on all of this, and I think that's what's going to come up as we come through the regulatory process. So the question is, do you want to start with this language and then go through all of that? I'm not really confident that you're going to get what you want in a timely manner if you don't start with the right premise and definitions in the first place. Thank you.
Thank you. So what would you like to do on that?
Well, I'm interested if other board members are concerned, if we need
Do
to
you
solve
need to
this.
take it back for
Want us to take it
clarification?
back, or do you want to move forward?
Sounds like there may be some clarification issues.
Heck, we've been working on it since 2016. I mean,
That's my concern, is taking it back. Is there value in doing that, or is moving forward and dealing with it with the ongoing rulemaking process efficient?
As long
guess
as
it's
there's,
It's going to be yours and the president's decision.
Yeah, I mean, I think it might be interesting to get, I think we've had it ourselves for a while, so it might be interesting to put it out there and have people,
Yeah, as long
provide
as there's a
language.
second bite at the apple, you might as well.
Yeah, I'm not sure we're going to be able to.
And I might suggest that this might be one that's a good candidate for a regulation hearing in addition to people submitting written comments. So when we notice it, we can include a regulation hearing where people can come and testify through the hearing as well.
Okay, that makes sense. All right, so, any additional comments? All those in favor of the committee motion? Unanimous. Go ahead.
Okay. Okay, next is consideration of legislative proposal to standardize the requirements, including qualifications for all designated representatives. And this impacts business and profession codes 4022.5, 4022.6, 4022.7, 4053, 4053.1, and 4053.2. So staff, just kind of, there's like a lot here. So staff identified 3 designated representative licenses that are not consistent or are inconsistent. And so what our thought here is to kind of try to line them up. It's the designated representative in charge of a wholesale facility. It's the designated representative of a 3PL. And the third one is a reverse distributor. Designated representative, reverse distributor. Thank you, Ann. So we kind of went through, during the meeting, we kind of went through a grid and asked ourselves like about 5 questions to make sure that we address this as efficiently and effectively and lined this all up. And so, as you can tell, this meeting was a lot about cleaning up legislation where there's things that aren't consistent. So we're just trying to really make things consistent. So the committee motion was to direct staff to work with council and the chair to develop proposed amendments to pharmacy law based on the discussion the committee had at the November meeting around these 3 license types, and to try to align the qualifications of those 3. So that's the committee motion. Is there, I do not need a second.
Oh,
But I will in a minute.
thank you.
Okay.
Is there any comments or questions about what we're doing here?
Members? Any public comments?
Oh, Siri said 1 moment.
Oh. Okay, Siri. All right, all those in favor of the committee motion, raise your hand. Thank you.
All right,
Move
so on
on.
the back table was our proposed statutory language. And you'll see that we went through and did designated representative in charge, 3PL, but we lined them all up so that they had the same, the same expectations, requirements. They also had the same, requirements as far as education. If you're a pharmacist, that it was the same, handled the same in the 3 different license types. So you'll see there's just kind of language kind of scattered throughout the 4 pages that is trying to align it and make it all consistent. So with that, the motion would be to approve of which I will need a second, would be to approve the proposed statutory language to amend BPC Code 4022.5, 4022.7, 4053, 4053.1, 4053.2 as drafted, and to direct the staff to secure an author to sponsor statutory change.
Okay, motion by Debbie, second by Alan. Any comments of the members? Comments of the public? All those in favor of the motion that needed a second? Thank you. Thank you. You've got a couple more, Debbie.
I do. So the next one is,
Oh, unanimous.
I think F, I don't think we can kind of move on. The next one is discussion consideration of the strategic goals. The committee recommended to remove strategic goal 1.1, which was to research and identify issues that result from unlicensed vendors in the marketplace to proactively maintain patient safety and health. And we actually feel like this is now being handled by the enforcement committee, that they're looking and reviewing the data, and I trust my colleague.
We embrace it.
Alan, so we do not need that to also be part of
Your
our
goals.
committee. And also to remove strategic goal 1.4, explore and possibly implement opportunities to use contracted organizations to administer the CPJE to increase access to the exam. At this point, we don't think that that's the right move forward, and so we also have taken that out of our strategic goals. So that's the committee recommendation, and we'd like to have approval from the full board for those changes in our strategic goals.
Okay. Any comments by the members? Comments by the public? Okay. All those in favor of eliminating those 2 items from the strategic licensing goals, raise your hand. Unanimous.
And the very last item is we have been working on a draft collaborative practice agreement for the pharmacist protocol for management of opioid use disorders. We did have Dr. Jasper here yesterday to go over his proposed protocol, proposed collaborative practice agreement. Our plan would be to approve this, and so the committee recommendation is to approve the collaborative practice agreement that was presented yesterday with the removal of the word electronic, and that had to do with health records. So the collaborative practice agreement said that it had to be electronic health records. We just said that there would be health records that would be maintained, and it would, pending review and approval by legal counsel, the licensing chair will review minor changes to the collaborative practice, and any major changes would come back to the full board for changes, for consideration. So that is the committee's recommendation on this collaborative practice.
Okay. Any comments of the board members? Any comments of the public?
Steve Gray for CSHP. Just for clarification, and you may have said it, and I may just want to emphasize it. The approval of this that was presented yesterday was one, if I remember correctly, it was about medication-assisted treatment protocol. Was that
Yes,
correct?
yes.
Second, and not anything else. So it wasn't about asthma or anything else, okay? Second, it was to approve a draft, a sample, something that could be promoted as if people want to know where to start, they could use it, but it wouldn't be something that is binding on everybody that has a collaborative practice agreement regarding that subject. Is that correct?
Correct.
Okay, so it's just an example.
So it's just a form that we're going to put on the board website that could, like you said, could be used in a collaborative practice
Right.
arrangement between a pharmacist and a physician that want to deal with opioid.
Right. Okay. And again, my concern is that the breadth of protocols and collaborative practice agreements is so broad. I would not like us to go down the path that some other states have gone down, where the Board of Pharmacy and in Maryland, the medical board have to approve every single one of them.
Yeah.
So, yeah. Okay. Thank you.
This is just really to kickstart it, try to get
Good.
it going.
I support it then completely.
Okay, any other comments? Okay, all those in favor, raise your hands. Okay, unanimous?
The second recommendation by the committee was to refer to the Communication and Public Education Committee to develop resources identifying treatment options and location of services that pharmacies can provide or post around medication-assisted treatment programs.
Okay, any member comments, public comments? All those in favor of the development of that, raise your hands. Thank you.
I think I'm done. I have no other action items.
Okay, then that concludes the action items. So we are going to go into closed session at this time. We should be, yes, go ahead, Danny.
There was item F on the licensing report that had a committee recommendation, but had an update where that said that you guys weren't moving forward. Can we quickly discuss that? Why is that not moving forward? This is dealing with the intern conferences at the schools of pharmacy. There was a committee motion to list.
Discussion, consideration, proposal to develop intern conferences for students.
Yeah, that one.
Recently enrolled.
Try to get out of it.
Yes. That was not,
No, I thought we decided.
oh, okay.
I thought we decided to stop that. We actually, because of interaction we've had with the deans, that there isn't, at this point in time, that it's not something that maybe that they want to embrace, that we thought we kind of wanted to relook at it.
Would the chair be willing to discuss in general terms what possible concerns there may be?
That's for them to share.
Okay.
Yeah, it's
Okay.
not our concerns.
All right. Thank you.
It's theirs. Yeah. Okay, so we are now going into closed session. Thank you for attending and participating thus far.
So, but are you planning to go back
we're
into
gonna come
open
back.
and then come back and address the remaining items? We just,
As mentioned this morning, we will come back to discuss other items from the committee that are not action items, and that'll take place after closed session. In other words, those items that don't need a quorum. I estimate that we'll be in closed session, what time is it? 10 to 11. Probably closed session, lunch. Why don't we return at 1:30? Licensure stats from Debbie Veal.
Oh, that's right. Are we all here? I guess we are. 2 minutes early.
Alan, you're up next.
You and I didn't keep the one from last. I have the update, and this doesn't have the updated, does it?
Alan?
Oh, I've got to sit down?
After Debbie's done with her statistics, I'll let you go back and
Okay.
cover the stuff.
Yeah, don't let your head hit the ground as I go through the statistics. The last little bit of licensing is a review of our licensing statistics. And the information we have here is for July 1st through September 30th. That's my stuff.
I'm taking it. I can't find mine. Go ahead.
I'm sorry, what? So just high level, the numbers are all in your packet. We've received 4,132 initial applications in that time period. We have received 129 requests for various types of temporary licenses, and we've issued 4,168 licenses, renewed 16,336 licenses, and in total have 140,727 active licenses that we're currently trying to manage. But one of the biggest things that we were focused on at our meeting back in September was processing times, because we're very sensitive that there was some issues with processing time. And so that was one of the biggest challenges that we put to the board staff at our meeting, is how we need to fix the processing times. So if you look at the chart that's in the materials, you'll see processing times as of September 18th. And then you'll see processing times as of October 22nd. So that's how the processing times have changed. And you'll see that there's been a significant increase, or maybe I should say decrease, but improvement, how about that? Improvement in processing times. So when you look at these numbers, for instance, when I look at pharmacy, deficiency mail processing time, on 9/18 it has 107, so that's what, when we looked, that's not an average number, but that means that there was one application that was still active and open that had been deficient for 107 days. You'll see that now has been cleaned up, and that the deficiency is now the longest application that's deficient is 25 days. So once again, not an average. This is actually, worst case scenario situation here.
Can I just clarify that?
Yes.
Sorry, it's actually that's the mail, because it's not the application itself, because the application has a different time. That's how old the mail is to be processed. I don't know that I'm saying that very clearly.
Okay. But the main thing I want to point out is that our goal as a board is the processing time of the applications. So the first two columns is supposed to be 30 days. You can see for the most part, we are compliant now. When we met in September, we had quite a few, matter of fact, most of them where we were right at the brink or non-compliant. And then the mail processing time is now, although not at 10 days, it's getting much closer. So I know the staff has put all hands on deck to try to really address this issue. They know from the licensing committee this is a very high priority. They've worked very hard at it. I think we talked about this yesterday, but even our EO got involved to try to knock some of these out. I think the challenge is going forward, trying to maintain where we are, but we've made the right step forward. So I don't know if there's any other comments from the board members. Seeing none, I don't know if there's any comments from the public.
Not for board members.
Steve Gray, CSHP. I was asked if you could comment on, since the last time we talked, on the progress with, or the numbers, and maybe you said it and I missed it, on advanced practice pharmacist licenses. And, is it, not only is how many, but is the rate leveling off, picking up? I mean, maybe there's not enough of them to even make a judgment.
Yes.
Go ahead.
So I would suggest that you look at the board meeting materials from July, because we do multi-year comparisons so that you can see some trending, and then the current stuff is in the packet.
I mean, I think what was in there was the number granted, but I didn't know how many had applied, or was that in there too? Okay.
Yeah, so just, we so far have licensed 574.
And so what you're saying, Ann, is that the number that are pending is in there too, or?
So licenses issued, applications received, and pending statuses are all in there.
Okay, thank you, I'll check that, thank you.
Thank you. Any other comments?
Okay, Mr. President, that's my report.
Thank you. Okay, now we're moving over to Alan Shad for the remainder of the Enforcement Committee.
All right. Thank you. All right, the Enforcement Committee met yesterday. As you know, the first thing that we talked about was the amendments to Title 16, Section 1765, relating to inventory reconciliation requirements for controlled substances, which we discussed. Then our next item that we did not discuss is reporting of drug losses. The chair report provides both the state and federal requirement for reporting drug loss. As noted, our board requires drug loss be reported. However, under federal law, the DEA only requires reporting of significant loss. In prior meetings, the committee reviewed drug loss data and discussed the possibility of establishing a different threshold for reporting of drug losses. Yesterday, our committee reviewed a draft proposal included in the meeting materials. In the general comments from the public indicated support for the approach. However, based on public comment, further consideration of the thresholds is necessary, including liquid and injectable losses. Routine inspection presentation, no need to go into that. And then we are having a discussion of recently enacted legislation impacting the practice of pharmacy. Specifically, AB 528 about the cures database. It's been expanded to include Schedule 5 drugs, and the reporting period is to be 1 business day from the date the prescription was released. This is going to take place January 1, 2021. Also, veterinarians will be reporting to cures as soon as reasonably possible, but not more than 7 days after dispensing. Further, physicians that do not possess DEA registration can now access the cure system. Also, the authority for delegates is expanding that individuals working under a prescriber will be able to retrieve data also. Let's see, we took action on AB 690, remote pharmacy dispensing sites, pharmacy technician qualifications. The next one up is AB 973, pharmacies compounding. AB 973, updated pharmacy law to explicitly state that compounding of a drug preparation by a pharmacy must be consistent with the relevant compounding chapters of the USP/NF. The new provision will augment the board's compounding regulations and BPC Section 4342, which provides board authority to institute any action it deems necessary to prevent the sale of pharmaceutical preparations and drugs that do not conform with the standards and tests as to quality and strength as provided in the latest edition of the USP. The next item is AB 1723, clinics purchasing drugs at wholesale. Essentially, AB 1723 is a technical cleanup measure. It conforms the maximum hours of operations for a primary community or free clinic is from 20 to 40 hours. We talked about SB 159 with the PEP and PrEP. And then let's see here, we dealt with SB 569, the controlled substances prescriptions declared in a local, state, or federal emergency. And then we go to SB 655. It's a board-sponsored initiative taking several technical and other conforming changes to pharmacy law, including validity period for pharmacy examination scores, a timely topic, pharmacy technician training provisions, advanced practice pharmacist renewal requirements, reverse distributor provisions, and government-owned facility fees. Also, we had a discussion concerning the board's enforcement statistics. And we noted a problem in the investigation data. Staff has reviewed and identified a typo in the information, thanks to President Lippy mentioning that. And there's 107 cases under review for assignment, averaging 11 days. 938 cases under investigation, averaging 178 days. 297 investigations under supervisor review, averaging 86 days. 127 investigations under second level review, averaging 53 days, and 255 investigations awaiting final closure. The next item is future committee dates, committee meeting dates, and it's January 29. All done, Mr. President.
Thank you for your report. Okay, next report is the report of the Legislation Regulation Committee, which is me. And the first 4 items are board-sponsored legislation, can be found in attachment 1. And actually, most of them, well, let me say, AB 690, AB 973, AB 569, and SB 650, SB 569 and SB 655 were all covered by Alan through the Enforcement Committee, as was AB 528, so I'm not going to repeat those again. Next would be AB 1076, which was signed by the governor on October 8, 2019. The bill requires DOJ to review summary criminal history information and identify individuals who are eligible for automatic relief by having their arrest and criminal records withheld from disclosure. It also requires the DOJ to provide automatic relief to eligible persons. By the way, all these that I'm reading, or none of the ones that I'm reading, have had any action items. AB 1264, Medical Practice Act, Dangerous Drugs, Appropriate Prior Examination. On October 11, 2019, the governor signed AB 1264, which specifies that an appropriate prior examination does not require a synchronous interaction between a patient and licensee, provided the licensee complies with the appropriate standard of care. Therefore, telehealth is acceptable as long as the appropriate standard of care is used. And as was mentioned in the committee yesterday, the impetus for this originally was hormonal contraceptives, but it then expanded beyond that, as described by Steve Gray yesterday. Next would be SB 601. As signed by the governor on October 12, 2019, the bill requires an individual or business that has been displaced or affected by a declared federal emergency or proclaimed state emergency to submit an application for reduction or waiver of fees required to renew, activate, or replace a license. Next, these are for discussion and consideration of board approval. They're regulations undergoing, these are the regs. I had just finished the legislation. Regulations undergoing formal review by the Office of Administrative Law. The board has 1 regulation package currently under post-adoption review. The proposed regulations to amend Title 16 CCR, Section 1749, related to the the board's fee schedule. This proposal updates the board's fee schedule by increasing the board's fees to address the structural imbalance within the board's budget. The board adopted the regulation during its June 21st, 2019 meeting. Rulemaking was submitted to OAL for final review on September 30th, 2019. The board requested an April 1, 2020 effective date. Next, discussion and consideration of board-approved regulations undergoing formal review by the Department of Consumer Affairs or the Business, Consumer Services and Housing Agency. The board's regulation to update the naloxone fact sheet was adopted during the board's June meeting and was sent to DCA for formal post-adoption review on August 28, 2019. This is in attachment 5. Next is discussion and consideration of board-approved regulations undergoing pre-notice review by the Department of Consumer Affairs or the Business, Consumer Services, and Housing Agency. Excuse me, we have a number of regulations undergoing pre-notice review, and you can find this in attachment 6. Within the meeting materials is a summary of each regulation as well as the current status. Regulations without any update and activity for 30 days are noted in red ink, and full timelines are included in the attachment. If you don't have a color printer, you won't be able to see the red ink, but it'll be a shaded line. I note there are still a number of regulations that have been in the same pending status since 2018. It's my understanding that the department established a dedicated regulations unit with the DCA's legal office. I believe it would be a fair expectation to see progress with many of these regulations by our next meeting. Our next meeting will be on January 29th, and that concludes the legislation and regulation report. Comment.
Steve Gray, as an individual pharmacist, a very concerned individual pharmacist about this subject. This concerns the pending regulation regarding the change in the naloxone fact sheet and related materials. Given the fact that that fact sheet seems to be taking forever to get changed, and I think the intent was not only to update it, but to also help facilitate some of the process. To streamline the process. We still have a situation that I think the board should look into, that so many pharmacies, I don't know the number, but virtually I would say the vast majority of pharmacies are not dispensing naloxone under their own authority. That the process is just too cumbersome, complicated, and since that law was passed in 2012, I think it was, effective 2013, so many other entities have the ability just to hand out naloxone without any problem. But the pharmacies are still bound by the protocol and process that was agreed upon between the board and the medical board. And I would suggest maybe that the chair of the legislative committee might want to put that on the agenda for consideration of revising the legislation to bring it in line, because pharmacies have a much harder time giving out naloxone than virtually any other emergency tech or anybody in this state. And so they're just not doing it. It just takes too long, and et cetera, et cetera. So that's my comment on that pending regulation. We still have no idea when that's finally going to be finished. It might be better just to go back to the legislature and change the process.
Well, it's at DCA for formal post-adoption review. I will contact DCA and see where they stand on that.
And I agree with that, but even if it is reviewed, it's still going to result in a process that is not making it practical for pharmacies to dispense naloxone.
Okay.
Thank you.
Thank you. No.
I think that regulation package is actually only about that fact sheet. And I think that the comment that you just received is actually more about the protocol itself, which is required by statute. So,
Therefore, it would require legislative fix.
Right. I think if you're going to move it to, the board, obviously you don't have a quorum, so, but recommending that it go to a
Back to the committee. Yeah. Okay.
reasonable action.
I think that also the chair of the committee sets the agenda, so I think the chair could determine it appropriate, independent of a board action as well.
Okay. In that case, I do. Okay. We'll take it up.
I'll just throw out there, licensing is going to be working on the PrEP protocol, so I don't know if you want to send that our way too, and we can do that protocol too.
We can talk about it together.
Yeah.
Thank you. Okay. Next. Well, I guess this, let's see, we have, update from the Department of Consumer Affairs. Regrettably, a department representative,
So I thought that Chris Castrillo was coming, but I'm wondering if he doesn't know that it's time because the webcast isn't working.
well, whatever, regrettably, a department representative is not available.
Right.
So, I mean, right? He's not here. Do you still think he's coming? I mean, this is the last item before we go back to, before we go into the petition, which is another closed session item. So. Huh? Oh, it's not closed. Okay. All right, but the judge won't be here till 2:30.
You want to check and see if he's available? We got a half hour.
Anyway, what I was going to say is that the department representative was not available. So we've been provided with a written update. Copies are available in the back of the room for members of the public. And the next item is a petition, which we can't get to till the judge gets here, which will be at 2:30. And after the petition, there is nothing left. Thank you for attending.
So effectively, it's over.
Yeah. We're not,
We'll catch an earlier flight, Steve.
yeah.
So the petition is during open session.
Yeah, we're not adjourned, but there's nothing left for you guys to,
No, but they may wish to stay for the petition.
yeah, but other than the petition, there's
After
nothing.
the
Danny wants to
petition,
come
you'll
talk
go
to us. I know
into
he does.
closed session, and then after closed session, you'll return to open session to recess, or to
Right.
adjourn.
There's a man with a beard looking expectantly at us. so-
Would it be safe to say that to put the meeting into a break via the webcast? Okay, excellent. We're on the record before the Board of Pharmacy for the Department of Consumer Affairs, State of California, to review a petition for early termination of probation by Glendora Medical Pharmacy. This is pharmacy permit number PHY 47517. The Board of Pharmacy case number is 5239, and OAH case number is 2019-101-156. My name is Wim Van Rooyen. I'm an administrative law judge with the Office of Administrative Hearings that's been assigned to preside over this matter. Today is November 6, 2019 at 2:30 p.m. in Sacramento, California. Will all the members of the board please identify themselves for the record, starting first with the board member on my furthest right.
Albert Wong, professional member.
Maria Serpa, professional member.
Ricardo Sanchez, public member.
Debbie Veal, professional member.
Greg Lippy, public member.
Alan Shad, professional member.
Thank you very much. It's my understanding that we do not have a quorum of the board present. However, we will be conducting this petition hearing pursuant to Business and Professions Code 4309 Subdivision C, which says that the petition may be heard by the board sitting with an administrative law judge or a committee of the board sitting with an administrative law judge, or the board may assign the petition to an administrative law judge. Where the petition is heard by a committee of the board sitting with an administrative law judge or by the administrative law judge sitting alone, the decision shall be subject to review by the board pursuant to section 11517 of the Government Code. And for your benefit, Ms. Randhawa, what that essentially means is because we don't have a full quorum of the board, and we're hearing this as a committee of the board, together with myself as the administrative law judge, after the hearing is closed and we've deliberated, I will prepare a proposed decision for the board's consideration, as opposed to a regular decision that would follow a board meeting where a quorum was present. Okay. At this time, may I please have appearance of the Attorney General?
Yes, good afternoon. I am Deputy Attorney General Christina Jarvis, appearing here pursuant to Business and Professions Code Section 4309.
All right, and may I have a formal appearance from the petitioner, please?
Paramjeet Randhawa from Glendora Medical Pharmacy.
Good afternoon, Ms. Randhawa.
Good afternoon, Your Honor.
So, off the record, before the hearing commenced, I explained the procedures and the matter to you, along with Ms. Jarvis. Essentially, the Deputy Attorney General will provide an orientation of the case for the board first, and after that, you will have a right to make a presentation to the board on your own behalf and explain why you believe that your probation should be terminated. You're welcome to have any witnesses testify on your own behalf, as well as your own testimony, as well as any additional documents you believe would be relevant for the court to consider. The board is particularly concerned with rehabilitation as well as your past probation compliance, and so that's what you can focus on. I'll just remind you that the board has had the benefit of reviewing your petition package, which Ms. Jarvis will introduce later, and so there's no need to repeat everything in that. Myself and the board can review the documents, but you're certainly welcome to highlight any particular things you want to bring to the board's attention. You won't receive a decision today. As I explained earlier on, I will issue a proposed decision, which will then be up to the board for final approval at a later date. All right, any questions at this juncture?
No, Your Honor.
All right. At this point, I'll turn it over to the Attorney General to present the packet and the case.
Thank you, Your Honor. This case is affiliated with a case that was heard at the board meeting of September 13th, 2019, for those board members who were present on that date. On September 13th, the board heard the petition for early termination of probation for Ms. Randhawa's personal license, and today the petition is for the pharmacy license. And therefore, I will keep this brief, but I do still need to lay the record and the foundation for this petition. This matter began as an accusation due to a pharmacy technician stealing hydrocodone from petitioner's pharmacy where she was the president and PIC. The facts are that on or about April 3rd, 2013, petitioner filed a report of theft or loss of controlled substances with the board, reporting a significant theft of hydrocodone attributable to one pharmacy technician. That technician was later criminally convicted of grand theft by embezzlement, and her technician license was revoked by the board by default. A drug audit showed approximately 93,000 tablets of hydrocodone had been lost or stolen. The investigation revealed that petitioner allowed 2 pharmacy technicians to sign for deliveries of controlled substances on 29 separate occasions between July 2012 and March 2013. The technician also admitted that she had been stealing hydrocodone for more than 2 years from the pharmacy. Ultimately, there were 3 causes for discipline against the pharmacy itself. First was failing to maintain complete acquisition and disposition records for controlled substances and dangerous drugs. And for reference, all of my code section references will be to the Business and Professions Code unless otherwise specified. So this was unprofessional conduct pursuant to Business and Professions Code Section 4301, subdivisions J and O, 4081, subdivision A, and California Code of Regulations, Section 1718. The drug audit showing the theft of 93,000 hydrocodone also discovered many other drug overages and losses of other drugs as well. The second cause for discipline was dangerous drug deliveries signed for and received by non-pharmacists, unprofessional conduct pursuant to Section 4301, subdivisions J and O, and 4059.5, subdivision A, along with Health and Safety Code Section 11209A. The third and final cause for discipline was failing to maintain the security of the pharmacy and provide effective controls to prevent theft or diversion. Again, unprofessional conduct pursuant to Section 4301, subdivision O, Section 4115, subdivision H, and California Code of Regulations, Section 1714, failing to secure the prescription department and provide effective controls. Accusation was filed on May 28, 2015, and a first amended accusation was filed March 1st, 2016. Petitioner admitted the conduct in full and entered into a stipulated settlement with the board for a 5-year term of probation effective at 5 p.m. on September 17th, 2016. Petitioner has therefore served 3 years of probation and has 2 remaining years. Petitioner has been 100% compliant with the conditions of probation and has fully repaid the investigation and prosecution costs of $13,489. Additionally, petitioner completed a community service program providing $10,000 worth of healthcare-related services to the community. Petitioner completed this on or about August 4th, 2017, so fairly soon after beginning probation. With her petition today, petitioner submitted 5 letters of recommendation, all of which were able to be verified by board staff. One of the letters was from her consultant pharmacist, and his letter is particularly important, I feel, to the board, as he discusses petitioner's compliance with the laws and regulations and appears to fully support petitioner's request to be released from probation today. I also want to note, again for the record, that while 4 of the 5 letters are from the same individuals that wrote letters for the respondent on her personal license, these are all actually new letters based on the dates the letters were signed and the content of the letters. So the petitioner did go back to these individuals and have them write letters specific to the pharmacy rather than to her personal license. And that also means that 4 of these individuals actually wrote 2 letters on petitioner's behalf. At this time, I'd like to ask that the petition packet previously provided to the administrative law judge be marked as Exhibit 1. This includes the notice of hearing that brought us here today, the acknowledgement of electronic recording, the actual petition packet filed by the petitioner, and then the underlying stipulated settlement and first amended accusation.
All right, I've marked the petition packet as Exhibit 1. Any objection to having it admitted? All right, no objection heard. Exhibit 1 is admitted.
Thank you, Your Honor. Then at this time, I will turn the floor over to petitioner to address the board.
Thank you very much, Ms. Jarvis. Ms. Randhawa, I'm assuming it's your wish to testify at this point? And let me just ask you, before you do so, do you have any additional documents that are not in the packet already that you want the board to consider?
No, I do not.
All right, thank you so much. Then I'll have you stand and raise your right hand, and I'll swear you in. Do you solemnly state, under penalty of perjury, that the testimony you're about to give shall be the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. Please have a seat. And since you don't have an attorney here to specifically ask you questions, feel free to testify freely to let the board know what you'd like to emphasize. Again, as I mentioned earlier, no need to repeat everything in the packet, but if there are certain things you want to highlight, you're welcome to do so. Once your testimony is done, Ms. Jarvis will have an opportunity to ask you some questions, as well as the individual board members. All right, please proceed.
Thank you. Good afternoon, ladies and gentlemen. I would like to start off by thanking the board for accommodating me today and allowing me the opportunity to come in front of you. As you may recall, I was here September 13th asking for early termination of my probation. However, at that time, it was pointed out to me that my case involved 2 petitions, pharmacy and pharmacist. Therefore, I am here today for the pharmacy. Glendora Medical Pharmacy was established in 1958 by a gentleman by the name of John Eckert, who still patronizes the pharmacy. I am the 3rd owner. We are inside a medical building, and my technician and I try to serve everyone with a smile. I have been at Glendora Medical Pharmacy since 2006, and it has been quite a journey, to say the least. My experience at Glendora Medical Pharmacy has taught me valuable lessons, one of which is to trust your employees, but to verify the trust. Another lesson is perseverance. My business has suffered tremendously over the last 3 years. However, I have persevered during this hard time. I want to make it clear that by no means am I trying to shy away from my responsibility of serving the remaining 2 years of my probation. However, you can see I have fulfilled every condition the board has set forth, and the conditions were extremely onerous. and I am asking if you can kindly forgive me for my negligence. I take full responsibility for it. Now I have put processes and cross-checks in place to verify and make sure all activities in the pharmacy are being conducted following strict guidelines. I conduct my physical inventory of all controlled substances every 2 to 3 months in order to prevent loss of controlled substances. I have a perpetual log for all my C2s, and they are in a locked cabinet where the pharmacist has control of them. The responsibility of being PIC and a owner are vast, and currently, because of the challenges I face every day as an independent pharmacy, I am trying to stay afloat. I am persevering through these tough times, and I am hoping I can put this experience of probation behind me. I am asking for your forgiveness for my negligence. I take full responsibility for it and will do everything in my power to prevent nothing like what took place will ever happen again. Thank you all once again for giving me time to appear in front of you today.
Thank you very much, Ms. Randhawa. Ms. Jarvis, do you have questions for the petitioner?
Yes, thank you.
Thank you.
Ms. Randall, I wanted to ask you about your relationship with your consultant pharmacist. This is your second consultant since you've been on probation?
Yes.
Okay. And what is your relationship with him? How often do you see him? He's written you 2 very positive letters, so I'd like to know a little bit more about how you 2 work together.
He comes in twice a month as a consultant pharmacist, so he spends anywhere from an hour to 2 hours going through my paperwork, my folders, my probation folder, and just looking over the pharmacy. And that's it.
Do you also ask him questions about your practice of pharmacy at all?
I do.
And you learn from him?
Yes, I ask him if there's anything I need to brush up on, or if he sees that there's something I'm not doing correctly. He watches me greet my customers, do consultations, fill prescriptions. So he overlooks the entire pharmacy while he's there.
And then the technician that stole from you, how long had she worked for you?
She was, I believe, I don't know, I hired her in 2007, I believe. And she was with me until I found out what she was doing, and then she resigned.
She resigned? Okay, thank you. I have no other questions at this time.
Thank you very much, Ms. Jarvis. And now an opportunity for board members to ask any questions, starting on my furthest right with Mr. Wong.
You have 2-year probation left. Is there anything you cannot do as a pharmacy and pharmacist that you? I mean, the question is mainly why you want to early. I mean, does the probation affect your business in any way?
It is an expensive process. I have to pay my consultant pharmacist every time he comes in. That was one of the reasons I switched over from the first one to the second one. And second of all, I have a notice in the pharmacy. I do lose customers when they see the sign. And thirdly, there are wholesalers that don't want to do business with me when they see that I'm on probation. So it's a battle.
That's a limitation. All right. Good.
Thank you very much. Any questions, Ms. Serpa?
I just wanted to thank you for your presentation and for coming before us on 2 occasions.
Thank you very much for having me.
Mr. Sanchez?
Yes. So I can turn this on. I wanted to do the same thing. It takes a lot of courage to come up here and talk to the board, and I want to say thank you.
Ms. Veal?
Thank you, sir.
I have no questions.
Mr. President, do you have any questions?
I do not.
And finally, Mr. Shaw, do you have any questions?
No questions.
All right. Is there anything else you'd like to present that we haven't discussed about, Ms. Randhawa?
Your Honor.
All right, thank you so much. Ms. Jarvis, anything else?
Yes, thank you. Just as in the matter of a recommendation to the board, I personally see no reason that the termination cannot, or the probation cannot be terminated early. However, as I've said before to this board, I am not a pharmacist, and if the pharmacists on the board believe otherwise, I would absolutely defer to their professionalism and judgment. Thank you.
All right, then that concludes the petition hearing in this matter. The record is now closed and the case is submitted for decision, and we're off the record in this matter. And it's my understanding that we will now go into a closed session pursuant to Government Code Section 11126C3 to deliberate on disciplinary matters, including proposed decisions, stipulated decisions, defaults, petitions for reductions in penalty, and any other disciplinary matters. Thank you very much for coming today.
Thank you again.
Thank you all.
Thank you. So we are now going into closed session one more time.
Question for you, will we adjourn after closed session?
Yes, we will. I mean, we will come back into open session and then we will adjourn.
Are we going to webcast? Are we going to webcast?
No.
Very well. Thank you.
Thank you.